Hi, it's Jenny B, NSWOC. Today we're going to complete our fourth part in our Pain in the Butt series. The last diagnostic is something called Hidradenitis Suppurativa. It is a chronic and often genetic problem that occurs. It's usually one of these ones when, no, it's not a pilonidal, it's not a perianal fistula, and it's not a perianal abscess. Often we're getting a diagnostic of HS. Now, again, as I said, it is chronic. It's something that never goes away. There is no cure, but there are multiple different treatment options, which is what I want to go through today, because again, it can be quite confusing for what we're supposed to be treating first and how we're going to treat it and at what point we're going to start certain things. So I'm just going to go through, but I'm going to start with the Hurley 2 staging system. So there are three stages. There is the stage 1, where there are small little lumps that occur. They're isolated. There is only, they're not connected in any way. Often it's just one at a time. I'm only going to use the ones in the axilla, the armpit region, because that's one of the two most common. So either in the groin or somewhere in the skin folds, in the groin or in the armpits or the axilla. Often can also happen underneath the breast. And in stage 1, you're just going to have the small little, they look like little abscesses that are forming. The fluid that comes out is often purulent. There can be an odor to it, and most people are concerned with infection. It's not just an ingrown hair. It's not just something that occurs a one-off, or that's that has the potential for large infection, but they often will require an irrigation and drainage to be performed. Most people present to the emergency department with this because they're actually quite painful and swollen and hot. And then they will do an initial stab wound to drain that out, and then they'll kind of move on. The problem becomes when these become multiple and or recurrent. So often they're not only in the same place, and often they can be anywhere on the body. They usually pick one site to start, either in the groin or in the axilla, sometimes under the breast, but it is they can be quite swollen, quite painful when they first start to erupt. The second stage is where you can actually see within the hair follicles, they actually start to tunnel. So the abscesses that form, they actually start to connect to one another, and again can also become quite painful and are much more difficult to treat because there's multiple tunnels underneath, and you can't really pack them. You can't really do much for wound care inside to try to help treat them, because again, they are likely not going to go away. They can by all means reduce in size and inflammation, but the reoccurrence rate is actually quite high. We just don't know how often or how frequent it's going to happen. That's very individual. And then third, we actually get where there's a very large area that has an abscess. There's multiple openings that they end up draining from, and this is where it's at a stage 3. So these are just the anatomical ones. These are your actual photos so you can see. So again, stage 1, they're usually just small little ones that occur, and then you start to get the dimpling that you'll see in stage 2, where they often are connected. This is ones that are less inflamed, and then they can actually advance into an area like this. So surgical management of these, it really depends on if you're able to find a surgeon that will try to do an excision. Some schools of thought are if we remove these, the scar tissue itself will, because it becomes a lot more dense, will actually prevent them from returning. So I know there are surgeons that have had success with this, and I also know many that do not. So it really does come down to surgical opinion on whether or not they want to provide an excision to try to remove these lesions, and often they do reoccur anyhow. So then they've just had that tissue loss, and it's not made a significant impact in the patient's quality of life or improving these. So again, that is definitely surgical opinion. For the most part, these lesions, we're just doing an I&D to help let the purulent fluid drain and let it heal from the bottom up or secondarily on its own. When we're at the stage 1, that's usually all that we're doing. The other thing that we can do is use a topical clindamycin cream. They will, by all means, apply to the area, and it can help with any infection that does occur. One of the other things I often will use is something called Dexedin. This is Dexedin 2. This is something commonly we do have here in clinics. There's actually a Dexedin 4, which is a chlorhexidine wash that the patient can use to just clean over these lesions. They can use that on any of these ongoing to just help reduce the bacterial burden to the area so that it doesn't, so the infection, and the bacteria there does reduce. One of the other really effective things that I've seen patients use when they're in the early stage 1 or stage 2 is something called Curlex. Curlex I have done a video on prior as well for what we use them for. This is PBMH infused gauze, or it is a large molecule chlorhexidine. That's the chemistry of it. So this does have some antibacterial or antimicrobial properties. So what the patient can do is they actually would end up taking a piece of this, they can fold it up and put it into and they cut it and put it into the area. It can help absorb some of the moisture, and it can help reduce some of the odor when they do have the lesions are draining. I often don't recommend them taping because tape can just cause more irritation, but sometimes we'll use something called Mepitac, which is a silicone tape, which is actually quite gentle. They will, you can adhere the gauze with it. It is skin colored, and then it will go on and off. You can tack and retack this tape multiple times, and it still maintains its stickiness. So those are a couple of the interventions that you can do right when we just have a stage 1 lesion. When we get over to stage 2, that's when there's other medications that become involved. One of the most effective things for maintenance of it when we're, kind of in an area like this where it's quite calm is something called Dapsone. We believe that due to the anti-infective properties of using Dapsone, just 100 milligrams on a daily basis, it can actually help with maintenance. Now, if they're more active and they are red and inflamed, we can switch over to a combination of 10 weeks of antibiotics, would be clindamycin 300 milligrams BID, and then also coupled with rifampicin 600 milligrams QID. That combination, for some reason, works really, really well at putting it at bay, reducing when there's multiple open abscesses and drainage to help with that bacterial load, especially if it's something that's been ongoing for the patient. Often patients do come in quite tearful because they don't know what else to do. They don't know why it continues to happen. It is one of the treatments that I will use. When they're somewhat more isolated, the other most effective treatment I found is the use of Kenalog steroid injections. This is usually mixed with some lidocaine, and depending on the size of the lesion, we'll inject right behind or into the lesion to help reduce the inflammation. This can actually prevent lesions from coming back for a couple of years sometimes, depending on how effective it has been. We can do the Kenalog injections monthly for a couple months if need be, just to try to help reduce the inflammation. Sometimes they can be used in this if you have like a new lesion that's come up to try to reduce that, but they've been actually quite successful for patients to use so that the inflammation reduces and they're a lot more comfortable. Now, again, absorbing drainage, trying to reduce any odor, and minimizing the bacterial load is really the primary treatment for HS. Sometimes you will see with the early stage 2 where they do have to open up the lesions, especially when they're on the bottom and there's a large amount of them connected, because that's the only way we're going to allow it to drain out. Often if we do some sort of packing as AMD or the Curlex, if it's a larger lesion, is super helpful to help treat and clean out the areas. But again, remember, these are chronic. There are lots of patient-centered concerns. Pain is often an issue, so we look at the WHO's pain ladder. I will attach the NIB document with this video so you can see where the treatment plan that I'm discussing comes from, because it is a whole series that dermatologists can order for it. A lot of the biologics and stuff that happen in early stage 3 are something that then a dermatologist does need to review and then order, because it's only a derm that can actually state that this is, the stage that they're in, and that those medications would be effective. I hope you find it helpful for some of the things that you can do when you do have a patient with HS. And just remember, the best wound is a closed one.